as you say, Tracy Tracy Taylor from NUH is not here, but as you mentioned, Rupert, welcome Rupert, wherever you are on the screen, but welcome, hello, and thank you for joining. Richard Mitchell, Sherwood Forest, is unfortunately not here. I suspect he's on leave or something, but I was going to say a little about him, but Paul, you are deputising as well, aren't you? I think wherever Paul is.
Yeah, that's right, Kathy. Yeah, Richard's otherwise engaged. He is around today.
He's otherwise engaged, and I was, and I think we've also got apologies from Mike Crow. But just on Richard, you know, if he'd been here, we'd have been able to say this to him. But this, I think, will be his last. Would have been his last board meeting with us. Claire's nodding, so I must be right. So I think we should note and record our thanks to Richard for everything he's done for the Nottingham and Nottinghamshire system, and obviously Claire, you'll be doing all of that, I'm sure, from the trust perspective. But it would have been nice to say goodbye to him sort of formally together. But if we could pass on, perhaps through you, Claire, as well, our good wishes to him, and he's done a lot for the system. He's been a really active player, and I think he's also, from certainly since I've been here, been very much a sort of a conscience, really, and you know, saying some very insightful things that I think we will miss. But hopefully, you know, everyone else will pick up the cudgels that he drops, and there'll be a new person as well in due course. So thanks very much to Richard. I don't know, Claire, if you wanted to say anything at that point.
Well, thank you on Richard's behalf, and we'll definitely pass that on. We've already said similar nice things to him at our public board meeting today. And as you know, Paul Robinson, as Deputy Chief Executive, will be acting Chief Executive when Richard leaves at the end of this month. So you'll see a bit more of him for some time yet.
Fantastic, thank you. Thanks, Claire. Is that it, Joanna, in terms of all the comings and goings, or is there any others I ought to highlight just now?
There's two last-minute apologies from Councillor Boyd Elliott and Councillor John Doddy. They've been called to a last-minute urgent meeting that they've had to prioritise, unfortunately. But Melanie Brooks is here with us today.
Okay, thank you for that. Yes, we all have these urgent things that just take over, don't they, really? So I'm sorry they're not here, but thank you for that apology. Conflicts of interest, I'm not anticipating anything particular on the agenda that anyone will need to highlight, but and we all keep our declarations up to date. That obviously is something I think that we do at the moment voluntarily, but it's good to see we do it. So is there anything anybody wanted to raise? Any conflicts they would like to highlight in advance? No? Fantastic. Minutes then of the, it seems like ages ago, but it's only 2 months, the 1st of July. First of all, I'd like to hope we could say they're accurate. Has anybody got any factual things they'd want to highlight? Seem okay? John Towler's shaking his head, all must be well. And the actions, there's one outstanding for Amanda, lessons learned from the COVID-19 vaccination programme and so on. Amanda, anything to update on?
Yeah, we were, John and I are intending to incorporate that into an agenda item. So we believe that there is some quite significant learning there of good practice and whole system working. So we'll build that into more of a showcase.
Thank you, that's great. Nobody else got anything on that? Let me just check the various chats and so on. Oh yes, and I see in the chat actually that Paul Devlin, who had alerted us, he'll be here in about 20 minutes. He's got another appointment at the moment. So I think that takes us through those practical things to begin with, and we can move on to our citizen's story, which is a really important part of our agenda. And I think Hugh Porter, you're going to lead us into this. We've obviously got some slides and a colleague with you as well. So can I hand over to you, Hugh.
Thank you, Chair. Yes, and can I introduce Kinsey Clark? Hi, Kinsey. Glad you could join us. Kinsey, I think many of you will know, being in assistant while, but is currently sort of working with Nottingham and Nottinghamshire Health Watch. And Kinsey's going to be doing most of the work in this session, so I just said I'd introduce it really. This is just a little bit different, I guess, from some of our normal citizen story, because most of our citizen stories are often based around a specific service. This is a little bit different, really. As an ICS, I think we're all absolutely committed to co-production and genuine engagement. And for the City ICP, as part of that, in March 2020, we did a listening exercise with NCVS and Health Watch to help inform our initial programs of work. Health Watch and then CVS have been then heavily involved in those programs. But after 12 months of doing those programs, obviously it was time to review how they were doing. We did a formal review. And as part of that, we wanted to go back to our sort of citizens and have a further conversation with them. So this is a sort of the outcome of that conversation, again, using CVS and Health Watch. Kinsey is going to take us through some of their findings, but also then sort of perhaps sort of bring a few questions of that sort of engagement question. So Kinsey, the floor is yours, really, if I can hand over to you.
Thanks very much, Hugh, and thank you, Kathy, and board members, and thank you for having me. I think this is my first time at this board. And yes, as you said, this is a repeat of event that was delivered in January 2020, and then we asked the same question in March 2021 to the stakeholders from the community and the voluntary sector to say what matters to you now. And I think I hope you all have a side of the short slides that we shared a couple of weeks ago. And really what mattered to the groups won't surprise anybody. But I think kind of if I kind of summarize them, they were COVID, surprisingly, was a big thing. Anything that was said by the group was kind of, was a theme under running COVID, and particularly so the wider determinants of health around COVID, and the fact that kind of impacted kind of our life is in different ways, and the burden and the pressure that is in the system as a result. And at the sort of behind that is sort of mental health. It was a very big issue that also came across quite loud and clearly. And that was both in terms of adults and children and young people, particularly the young people, sort of the intergeneration kind of parents becoming teachers, children losing socialization and peer support and going to education. So at that point in March this year, we were kind of literally just coming out, you know, of some of the worst parties. So things were still quite hairy. The sanitized schools were still closed and things were not brilliant for parents. And of course, that comes with a huge amount of stress, and everybody kind of learning new skills and managing households and parents and grandparents and children living together and combined to without places to go. So that kind of the pressure, sort of on the one hand, the self-isolation, and on the other hand, the kind of living together and being forced together came across as impacting people's emotional well-being. And there was a clear message around domestic violence being on the rise, and the fact that people who were experiencing domestic violence, particularly I mean women, and were kind of lose the opportunity and the spaces and the safe places and the groups where they would go normally. So perpetrators and victims being locked together by COVID, and basically people were experiencing a greater level of domestic abuse, and also children were witnessing a greater level of abuse. And another theme that came very clearly and loudly was the fact that, I know this was known to us before, but the pandemic highlighted particular health inequalities within the Black and Asian and ethnic minority communities, and the fact that they were disproportionately feeling the effect of COVID. And that also deprived communities, and being among the deprived communities, and the kind of the economic breakdown and the sort of the loss of jobs and the loss of opportunities. And that was also exasperating the fact that they were already suffering some sort of a health inequalities. And I think so they were kind of the headline is really those kind of areas. And I think one other point that was highlighted very eloquently was, unfortunately, despite all the efforts that we are all making collectively, services were still disjointed. And so everybody was dealing with their window, kind of dealing with their bit, whether that is, repairing the broken leg or dealing with someone who is experiencing anxiety and depression. But unfortunately, kind of seeing the whole person and having a bit of an holistic approach and person-centered communication and a smooth transition from A to B. People who attended the workshop said that unfortunately wasn't always the case for them. So that being that, and they were, when we asked it also, what would they have any suggestions for improvement? I think, as you will see on the slides again, I think sort of co-production came clearly. Perhaps I should start sharing my screen at this point to see if it works. And sorry, do that now. Can you see that?
That's come up, Kinsey, thank you.
Oh, great. Thank you. And so, yes, one of kind of the new approaches or their advice and suggestion is included having really a greater collaboration between the mainstream services and the voluntary sector. So co-production with the communities, that basically goes co-production with the kind of citizens and the wider public. And I am aware that as ICS, we are actually currently working and looking into the issue of co-production. And there was also kind of the communities were saying, perhaps we are not shouting loudly and clearly enough to central government. I know that's an interesting point, but basically we should be getting a kind of our share of the resources, because obviously, although people appreciate that local leaders and commissioners and providers were doing their best, maybe generally as a system, we're not really getting our ask. And so there was kind of, the community was feeling that perhaps we could be asking more and making our case a bit more clearly to central government. And obviously it was also quoted the fact that where there is a will, there is a way. And the example was given when we initially kind of hit by COVID, we had a scheme which said everybody in, and basically meant every homeless person were housed. Suddenly there were resources, suddenly there were accommodation, suddenly there were goodwill and collaboration, and we could do it. So I think there was a point being made that if we really try and work together and have a genuine intention to resolve some of these complex and ongoing problems, we can do. So I think the question is to you as a board today is basically, what do we do with the feedback? And it come to the board here today, and you and I were kind of with few questions really. But we won't call it a challenge, but we call it a sort of a maybe kind of to kind of nudge and maybe have a discussion. How will the board consistently take the temperature, so to speak, of our citizens, especially across diverse communities and sectors? How can the ICS work with Health Watch and the CVS sector to support this feedback and generally to work with the system more effectively? And how will we use this information? I think that's a question to the board. And most importantly, how will the ICS demonstrate transparency that this feedback is influencing decisions, and how will this be communicated to the communities to help us start building trust? And I think it sort of not having really a full trust and faith in the system was one of the things that were said in both of these workshops. So over to you.
So just thanks very much, Kinsey. And I say, I mean, I don't think we're going to solve all this, but I think, I think there's no perhaps huge surprises there, but I think it's always good to be reminded of what our communities are sort of experiencing, of things that are high priorities. but I think that, you know, can now put those questions together, because one of the things we've obviously been dealing with importantly is during the COVID vaccination is vaccine hesitancy, and part of that is a sort of in some of our communities sort of sensitivity and perhaps distrust of the system and the public sector, and we obviously have a role in trying to sort of reduce that and build trust between ourselves and our communities, and it's certainly part of the reason we did this sort of revisit was it's sort of going back that continuing cycle with our communities. So I just thought to put those questions out there to start a little bit of a brief discussion today, obviously not to sort of solve that. And certainly, for instance, I think Alex is here to be really interested to get sort of feedback. So thanks very much, and happy to take questions.
Well, thank you very much, Kinsey and Hugh. I thought that was a tremendous example of really, you know, how you're able to listen to people and the potential difference it could make. So, you know, great to hear, and that made me really think here about, you know, particularly that last point on your questions. You know, how do we get that feedback and try and build that trust? Now you might want to unshare so that I can see.
Yes, thank you.
I have captured it so that I do have those questions if we need to come back to them. But let's just get one or two reflections on that and thoughts. I think I've got Michael would like to come in, and then Alex. Thank you.
Yeah, thanks, Kathy. And thank you for the presentation, Kinsey. There's clearly a role for the community voluntary sector. There's clearly a role for marketing and research. But it seems to me that one of the really powerful resources that we have are our own staff, and the diversity of our own staff and their contacts within communities. I suppose for me, the question is whether we're making full use of that intelligence, whether we're encouraging our staff to feedback the issues and concerns that they face on a day-to-day basis, working with many of these communities who are disengaged. And so I hope it's something that we can sort of reflect on as we go forward. As Hugh said, it's not something that we're going to solve today, but I think there are a variety of methods that we can use to get closer to our communities.
And thanks, Michael. I'll gather up a few thoughts, and then if there's anything, Kinsey or Hugh, you want to say, but I'll take Alex and Amanda, and then we'll perhaps come to some conclusions. As you say, we can't solve all of this, but I think we can perhaps put a few markers down about the way forward. Alex.
Yeah, thanks, Kathy, and thanks, Kinsey and Hugh. It's a really brilliant worked example of fantastic best practice in this space. So that's why I was so keen to have this kind of showcase today. So I think we should convey our thanks from the board to the team in the place-based partnership that have done a really, really good piece of work there and are continuing to. I just wanted to signal to the board as well that at our development session week after next, I'll bring a first kind of flavour of how this thinking is starting to influence some of the wider thinking about how our system can, as Kinsey very eloquently puts it, continuously listen to our citizens and then act on their feedback. And there are a series of workshops which many members of organisations represented here by colleagues are attending over the next 2-3 weeks to really kind of flesh out that approach, with a view to the November board having a kind of wider discussion on this topic. So this is almost the first part of, I think, 2 or 3 opportunities for us to start to get our heads around this as a board and agree what the future looks like. But yeah, I think it's a really helpful first share of some really great work. So thanks again.
Yes, thank you. I think it shows what can be done if you know how, which is really important. Amanda, do you want to?
Yes, thank you. Building on what's been said, actually, again, I think it's really good to see that work has happened. I think in terms of the questions around what will the ICS approach be, I would say that would that will be a collective approach, because I think we will, if you like, rely on to some extent the place-based partnership relationships, and that's what, you know, why we sort of work very closely with you and the CVSs and others as well. So I think it's really to say, I think we do need a systematic approach, and the transparency that you described and the responsiveness around that. And also I think to, as Michael said, make sure that we're maximising the natural networks that are there as well, whether they're staff or other community networks. So I think it's very much a partnership endeavour, not a kind of something removed from the teams that are in place. Thank you.
Thank you, Amanda. So just reflecting on that, I mean, obviously this is a topic we could spend the rest of the afternoon on, in all honesty. And I think Alex has set out some of the arenas we've got in which we can pursue this over the next while. To me, though, this is at the heart of why we're here and integrating. We're trying to listen to the people we serve and engaging with them, not telling them what we're going to do, but engaging with them so that we can respond. So I think that's important. And I suggest that we take your questions into those sessions, Alex, you know, that we're going to have and use those. And I think this business of being able to feed back to people, what have we actually done in response, is so critical. And so often people go to things and they give their opinions and they never hear anything more. And that doesn't build any trust at all, does it? It doesn't demonstrate anything. So, you know, I'd like to add my thanks, if you, Kinsey, to pass back to all the people who must have been involved in this. Thanks for doing this. But I think it's a really good example of, and we need to build on this, and it needs to happen across the whole of our system. But I think, as has been said, we'll rely heavily on places and localities for doing a lot of this. It's practically very, very much more difficult, isn't it, across 1.2 million, is it, people that we have now? Adele, did you just want to add something there?
Just briefly, yeah, just to say, really welcome this piece of work, and welcome the sort of recognition we are giving as a system to the importance of the voice of people who are affected by, you know, by the decisions we make and things happening in their communities. I think probably one to just take away and chew over, and certainly one for us to think about at Health and Wellbeing Board level, is how this boils down to the primary care network levels and how we make sure that that works and is sort of threaded through all parts of the system. Because I think it's really important that our primary care networks are working to the, you know, to the programme that we're kind of developing in co-production with that sort of co-production approach with our communities. So, you know, in everything that we do, we are sort of we're seeing it through that lens, the understanding we've got through our communities, through our data, and you know, and really listening to the wisdom of those that are, you know, that understand the way that, you know, how the challenges there are, the barriers there are to living well, living healthily. So, just a thought really about how we are going to just make sure it all ties through right through the system, and you know, so it goes further than board level, further than health and wellbeing level, and actually sort of you could see it in the work of everyone in all parts of the system. Thank you.
Great, thank you, Adele. I think that's a good point to close that. But this is something we will recurrently discuss. And thank you, Hugh and Kinsey, for kicking us off on it. And we look forward to further discussions. So great, thank you for all of that. And we've noted in the sidebar there, welcome to Hayley as well. I've just noticed I've, in my rush, spelt your name wrong, but forgive me, I'm trying to do more than one thing at once, clearly not very well. But yes, let's move on then to the next item, which I think is for myself and Amanda to talk about our sort of updates, really. And you've got a paper there. I'll kick off, and then I think, Amanda, if you would come in on some specific things, that'd be really helpful. So I'm not going to go through the paper, but I just wanted to say a few things about where, I think we are. I think we noted at the beginning of the meeting that the start of September is really the sort of start of the second half of the year. And I think it's, as a system, it's really clear we have a huge amount to do. And I'm pretty confident that we're on track with most of that. We'll hear more later from John Towler and the Transition Committee. And I think that will probably confirm that we're on track. But we have got a lot to be doing at the moment. And whilst you may recall that when I have talked over the last few months, it's been about how we avoid getting sucked into the sort of structures and governance to the detriment of, the sort of thing we've just talked about with how we can make a difference for our people. But there is a certain amount we need to do between now and April the 1st in order to be set up as an integrated care system. For example, we must have our integrated care board in place. We must have our ICP, our integrated care partnership in place. We must have established how we're going to sort out the governance for our places. And worth noting that, of course, we have expanded slightly since we last met. We have Bassett Law with us now, and we will ensure that representatives from that place will join our board, and Amanda will ensure that happens. But great welcome to Bassett Law. I think that'll be a tremendous addition to our system. And I think we do recognise that for some people, that won't have been the outcome they wanted, but we welcome everybody, and the work we're doing with Bassett Law at the moment is really positive. So I think that's a great start. So I think what my message is really around all of this is we need to continue to focus on the delivery of some really important things across the system. We've got the recovery going on. We've got the next phase of vaccinations for COVID going on. So there's a lot of big things. We've got to prepare for the winter. We've got financial things. Stuart will update us on this later on. We've got a lot of big things that have to happen. We must get our system set up, but as you can see from the agenda, we've still got our focus, and really important, on reducing health inequalities, some of our signature areas and so on. So I think we'll try and juggle all of those, but I think I'm just setting out that for the next few months, if we thought it was hard work for the last 18 months, I think the next few months are going to be hard work in a slightly different way. And it's good that everybody's working together on all of this, and that's the sort of spirit we need to keep going. But I want to apologise in advance if we have to go through a little bit of governance stuff and rather structurally stuff. We'll try and minimise it, but I don't think we've got a lot of choice. So I did want to just highlight that. Other things you can see in the report, but I'd like to bring Amanda in for a few specific things. And I know you're going to talk a little around quality, which is such an important thing for the system, and any other items you want to just add, Amanda, please.
Yes, thank you, Kathy, very much. I just wanted to highlight that following the decision about Bassett Law, colleagues from Bassett Law are now very much part of our transition programme and the Transition Committee. And as Kathy says, we'll extend invites to all really areas of working. And a very positive start also in terms of some of the developing relationships with Bassett Law as an additional place. I just wanted to highlight as well, probably related to what Kathy's just said, I think we are at a really important point in our development now, and this next sort of few months, we will really need to sort of build on the momentum over the last 6 months. And we do have some key workshops in September to really inform our implementation plans in the run-up to statutory status. So I think that's really exciting, actually, and building on the conversations we've had previously. I'm also really pleased, Cathy didn't mention it, but to say that Cathy is now confirmed as chair designate for the Integrated Care Board. So that's really good news. And so I think, that's a couple of the Bassett Law and Cathy's appointment, a couple of really important pieces of the jigsaw of our new system. I also wanted to draw the board's attention to the sort of developing role, actually, of the Quality Assurance and Improvement Group that we have, which is really, I think, improving the sort of whole system visibility and ownership of areas of quality, and learning from each other more in a much more open and less sort of organisationally focused way, and also joint solutions around things. There are a couple of areas of, if you like, enhanced system surveillance that I wanted to bring to the board's attention. So our Healthcare Trust colleagues have been really proactive in terms of sharing some of the learning and developing work around open cultures. And there are some quite considerable pressures on those services at the moment as we're sort of coming out of COVID lockdown. And then the other sort of very notable area is around maternity at NUH, and other sort of areas of concern around the sort of related culture, incident reporting and safety and staffing. We have established a system-wide quality assurance group, which does have a number of stakeholders on. And that's, again, a really good engagement in that group and a sort of overview of an oversight of progress there. And the system and colleagues from NHS England Improvement are jointly commissioning an independent review just to ensure that all the key themes and issues are identified as a result of that. So there is considerable system support, there's mutual aid and support around some of the governance processes as well. So I just wanted to highlight those, Cathy, because they are in the quality report, and I think it does signal a more system approach to these issues. Thank you.
Thanks, Amanda. Are there any comments or questions on any of those items before we go on to the next paper, which just takes us through some of the transitional issues? Happy to take any questions or comments. I can't see any hands. Oh, can I?
John's got his hand up, Cathy.
Yeah.
Hi, Cathy. John Bruin, Chief Exec, Knox Healthcare. This has been sort of referenced, and in relation to what Amanda's just said, and it might be seen as a bit of a statement of the obvious, but I just wanted to sort of overlay the system challenges on top of all that governance and work that you've described, and people are aware of it, but right across primary care, social care, community, ambulance, into the acute trust and our own trust, I think we would say it's probably the most challenging time many of us ever worked in over many years. One of the biggest issues is managing staffing on a day-to-day basis. There are some obviously differentials and hotspots and less hotspots, but it's really, really tough out there. And with the uncertainties of where the pandemic's going, which way's next, it's very difficult. And whilst not wanting to sort of be making excuses, I just think it's really important that we're cognizant of that massive challenge. Some of us also got CQC issues, either imminent, pending, or in play, and it makes a really tricky environment, and all the more reason for us to work as well as we can systematically together, because we have got a lot of expertise and skills in the system, but if ever we needed it, the time's now. Thanks.
Thanks, John. And yes, and I think you've sort of articulated somewhat better than I did around, the next few months, I think, are going to be really, really hard and tricky. And I think, you know, I think we've got to remember that all our services, whether it's in a trust, primary care, local authority, it's all built around our people who are working incredibly hard. They've had a really tough 18 months. And I think we should record our thanks to them. Again, I don't think we can ever say it too often, formally say, you know, thank you to all of the people who are working. I was very tiny little hope that people may have had some sort of recuperative holiday over the summer and getting them ready, but you know, that will soon disappear in people's minds as the nights draw in and it gets even busier. But I think what you're saying, John, is what I think we're all hearing, is that it is busier than it's ever been, which is extraordinary, really, isn't it? So well said, and let's stick together, because the only way we're going to get through it is by working absolutely together and helping, you know, one organisation, one bit of the system helping others out where they can. So I think that's helpful. Adele, did I see your hand up?
I've lowered it again because I think we're coming back to some of the issues around quality, and I would like to, just add my thanks. I think we all want to the staff that are working in tremendously difficult conditions, and that applies right across the system in the adults workforce, and just to thank them, but also, you know, and this is picked up elsewhere in the agenda, just to add that sense of the really difficult workforce issues there are out there, and you know, the work we need to do to bring new people into our workforce, which in turn will help address some of those wider determinants, putting money into purses in the city and the county. So you know, but that's in the short term. We have some real issues around workforce that I know we all want to work together to address. I know it's picked up elsewhere in the agenda, but thanks to everyone out there working now.
Okay, thanks, Adele. And I think it is worth noting that, you know, the ICS will have some particular work to do around people and culture. And again, Amanda, I think that's something that at some stage we will come back to in a big way, won't we? Because that's quite it's a hugely important agenda. The one workforce concept, etc., etc. Okay, so I think that is, you can read other things in our report there, but I hope that helps keep everybody up to speed, a little bit of the sort of context. And then, Amanda, if I can hand over to you largely, our transition to becoming a statutory ICS. We've touched on some of this. Perhaps if I just say a little bit, and then if you could, you know, just sort of highlight a few things from the paper. Again, I think everybody's been able to read that. But you know, as you said, yes, I appear to have been you know, anointed into post. So in effect, I'm the first member of the Integrated Care Board, I suppose. The next key things for us, though, are we need to appoint a chief executive, and then there'll be a series of other roles. So there are some practical things we do have to do. We're talking later on the agenda about provider collaborative, and I think that's a huge step. When we get to that item, I think that's going to be a big step. We've got place to discuss and so on. So there's a number of things we must have developed and got sorted by the 31st of March, if you like, in order that we can have a safe handover into this new world. But you know, all of that is in hand. Amanda, do you want to just flesh out one or two of those key things? And you'll probably want to reflect to everybody that the amount of guidance that's coming down, I'm just really relieved that we're past the days of it all being posted out, because otherwise I think Royal Mail would be in some difficulty. It is actually arriving electronically, but it comes at such a speed that you literally can't keep up with it. But the team are doing a great job at interpreting it. Amanda, over to you.
Thank you. Yes, thank you, Kathy. There was a couple of bits I just wanted to say. I think, as you'll see from the highlight report, the transition programme is well established and work is well underway in all of the work streams and feeding into our board development sessions and board, such as the paper today on the provider collaboratives. I also just wanted to highlight that the OD offer is really timely, and that will be shaped by a number of people, and to include colleagues from Bassett Law as well, so that there is a sort of inclusive way of shaping what that OD programme looks like. So we're very grateful for that support and resource that we can draw on. I think I touched on a couple of other elements from in the previous report, but in terms of the guidance, because there is so much, it's quite helpfully now being split into things that we absolutely must do, and there is something called a readiness to operate statement, which we will which will be like an assurance tool for us and colleagues in NHS England in improvement, in terms of have we got all the absolute essentials for a safe landing in place for April 22. And then there's some that is more around, good partnership working and other sort of guidance that we might want to incorporate. And again, I think some of the conversations we've had are about understanding where we think we realistically can and want to get to for April 22, but that will be a starting point rather than an end point, if you like, in terms of some of our integrated working and the way that the different parts of the system are going to be working together. So those were the points I wanted to raise, Kathy. Thank you.
Thanks, Amanda. I think one of the principles that we're trying to maintain here is that wherever possible, we get a consensus, we get engagement from you all, which is why we've got a series of things coming up in September in terms of development, that we'll go through those and hopefully everybody will feel like they are engaged in those. But, there are a few things we're going to have to be pragmatic about in order to keep moving forward. And as Amanda says, we need to get to the 31st of March into the 1st of April in a safe way, but that will be the start of the end of the start of the journey rather than the full journey, if you know what I mean. We will have to then build from there. And one of my fears throughout is that we lose momentum through the next few months on the good stuff on the ground, and we don't want to do that. Any comments or questions? Did I see a hand up from Paul, or was that an imagination? No, it was imagination. Anybody else? Is it all as clear as it can be at this stage? Or is there anything more we need to be doing to keep people updated and engage you? I'm going to take no questions as yes, it's probably okay at the moment, but do let us know if it isn't at any stage, because it's quite hard, literally hard to keep up with the guidance. I'm personally struggling to read it all fast as it comes in. Fortunately, I don't have to do the detail, I don't think, but that's important. So let's move on then. John, great to have an update on our inequalities strategy, something which is a really important and has been a very positive thing with Nottingham and Nottinghamshire. I think we've all felt it just needs a sort of re-highlight, refresh, and I think constantly Adele is always, perhaps Adele's going to adopt the Richard's role of being our conscience, but Adele's always reminding us about the wider determinants and has already managed to get those words into today's meeting. So can I hand to you, John, just to we've read your paper, of course, but if you could just highlight things for us, that'd be great.
Yeah, thank you. Thanks, Kathy. And just to note, Chris Packham is on the call as well. And so if there are any hard questions around health inequalities, I'm sure Chris will be delighted to answer them after I've given it an abject attempt. So I take the paper is read. There's a few things just to highlight. I think that the first thing is I think fairly clear to everybody that health inequalities is now writ large across much of the national agendas, and it seems a bit of a golden thread really as to the transformation that's required across sort of health and social care services. And if we can tackle some of the entrenched health inequalities, then we'll be really adding value and improving outcomes to large sectors of the vulnerable populations. So it's a really important piece of work to focus on. I think in terms of where we've been and where we are now, I think historically we've always had some really impressive data and reportage, if you like, in the system. But I think to offer a critique of it is that it's sometimes come after the event. Whereas I think one of the fundamental things that we'd like to try and aim to do is to use the data and information to inform services going forward. So, for example, just one specific, if we could get some analytics by deprivation and ethnicity of our DNA populations, for example, that would really inform how we can tackle some of the inequalities that we see in the provision. In terms of where we've got to, the paper's fairly self-explanatory, really, in terms of strategic objectives. The priorities that are also listed there from health and care services perspective. Much of the current work has been focused on the vaccination programme, which has been a bit of an opportunity in terms of live testing of some of this, really, and we've had some good early results and improvements in how we've focused our vaccination efforts based on some of the really detailed data that we've been getting from the information unit. I just wanted to focus a little bit on the page that's headed Conditions for Success, which is paragraph 8 in the paper. And just to take you people through how we've stratified the programme, if you like. So we've now got this ICS Health Inequalities group, which I chair. We've got really good membership of that from across the health, local authority and public health bodies. And as I said earlier, we've got some great skills and expertise in that group. And it's a broad church. The meeting's only met a couple of times, but I'm confident that we've developed a sort of principles and approach that will bear fruit in the longer term. One of the key things we've got to do is to align where we focus the work. So, for example, when Adele talks about that some of the wider determinants, we can think about things like air quality, transport. You know, that's a big system issue. But then the layers down, what were ICPs, now called place-based partnerships? Hope everybody's keeping up with the nomenclature. Down right to PCNs and local neighbourhoods. We've got groups working at each level to make sure that the work they're doing is targeted to that specific domain. And some of the work that we've got going in place-based partnerships and in the primary care networks is, I think, really impressive. And then the last point about conditions for success to reference is the Strategic Analytics Unit, the SAU, which I referenced at the start. So this is, the aim of this is to bring all the intelligence, the data, the different pockets of work that we've had going on into a more systematized analytics output to really inform things that we want to do going forward. There's a lot to do. We've got a good outcomes framework. We've got the big ticket projects like alcohol, tobacco use, weight reduction. There's, I think, some early wins that we'll be able to keep the board sighted on, but I would emphasise this is very much early days. And I'll probably leave it there, Kathy, because there's probably quite a a number of questions and comments. I'm happy to take on those and address them. Thank you.
Thanks, John. So I think it's a really helpful paper. And I think, as you say, this is at the heart of why we're here, isn't it, really, when you think about the purpose of integrating and coming together. I'm sure I'll take several questions or comments on this, but I think we need to make sure we have a mechanism for threading this in and being really clear what we're actually focused on and what we're going to see then make a difference in measurable quantum, so that it's not just something we thought was a nice idea, but actually we are going to hold ourselves to account for measurable change. And that's the bit that I think is really, really tough, because some of these topics we've talked about for many, many years, and I haven't seen a vast amount of movement. So we're going to do something different. We have to. So let me try and think of the order I saw people's hands. I saw Claire first, so I will go with you, Claire.
Thanks very much, Kathy. So I think this is a really good paper, but of course, as you say, Kathy, many of these issues are recurring on all of the papers around health inequalities in terms of long-term smoking, obesity, alcohol, all of those kind of social issues that we know have such a big impact on health access and health outcomes. So I wondered, in terms of how we are mapping out what footprints of services we have in some of those areas as well, and recognising where in some of those deprived communities we don't have the same level perhaps of GP services or of other healthcare services that we need. The second issue kind of relates into that, which is in those cases, we're often also relying upon digital exclusion, digital opportunities. And so how do we make sure that we are not excluding some of those communities, and we are providing places near to them where they can get support to learn how to use NHS app or to use other digital facilities. And then the final thing is, we know that a lot of this is about changing attitudes for the long term, and schools and children are a huge part in that. So how are we building in that within that long-term plan in health inequalities, the work that we're doing or supporting with schools and with young people to change attitudes in terms of healthy eating and provide additional support, for example? So lots in there. Great. This is a great paper with lots in there, but I'm just sort of looking for what else we can do.
Great, thanks, Claire. Can I suggest I'll pick up another question, and then some of that I would just wonder if Chris Packham would be well placed to perhaps respond on some of that, John, if that's helpful. I'm just giving you warning, Chris, to have a think of that while I take a question from Michael, and then I think we've got Hugh, John and Tim, and then I think that'll have to be it pretty much on the questions for this one.
Yeah, like Claire, I welcome the paper and the progress that's been made. I suppose as our key objective, we've got healthy life expectancy. And at its most stark, health inequalities is about the difference in life expectancy between some of the areas of Nottingham and Nottinghamshire and between some of the communities that make up that. I suppose what I don't see is a read across from this strategy to the allocation of resources and the resource strategy, because if we're really serious about trying to tackle some of these issues, it does mean that we've got to switch resources and move them into other areas. And really, I can see no evidence of that as yet. So that's perhaps the big issue that the board has got to grapple with if it does want to make the sort of difference, Kathy, that you would like to see.
Yeah, thank you. The allocation of resources is quite an interesting one, isn't it? And there is something here about joining up our different elements. So when we talk about finance, we talk about workforce, we talk about health inequality, how do we join it rather than have separate conversations? But right, let's try and answer some of those and then come on to the other people. So Chris, there's something about the mapping. You may not be the best person, it might be Amanda or somebody, but mapping of services, the digital non-exclusion and changing attitudes. Do you want to just give your perspective, sort of a public health type perspective or whatever?
Sure. Thanks, Kathy. In terms of mapping, I think we've still got to work out how to use primary care data as part of the picture around health inequalities, because clearly of the 10 to 20% of health gain that is produced by health and social care, the other 80% plus being wider determinants, 80% of that is in primary care. And so the mapping of what patients are getting in relation to prevention at one-to-one level is critically dependent on what's happening in primary care, as has been said. And I think we are still working on how to do that across the ICS using the GP data and PCN level data. So that's in progress. Digital exclusion, a huge issue, nowhere more so than in the Healthcare Trust where I work. And there is quite a lot of work going on across connected knots in the ICS, in the IT space on digital exclusion. But we're very conscious that the councils have done quite a bit on this, and we're trying to work with them on that. The wider determinants is clearly the biggest issue in relation to both education, poverty, and a whole range of things. And what this paper does, although it makes reference to it, I think in future iterations, you'll see a much stronger emphasis on wider determinants, because we have engaged the DPHs very carefully in this work, knowing full well that actually that is beyond the work that the health and care sector does, is the critical issue. And then in relation to resources, we have to make a quantitative argument in relation to movement of resources or prioritisation, and to some extent that's why the strategic analysis unit and using population health management techniques is so important, because we recognise that we have to make a sort of rational and logical argument in that respect in terms of health gain.
Thank you. I mean, we could spend quite a bit of time on the allocation of resources. I know I've had some discussions with Amanda about there are certain things we're bound by, aren't there? I think, Amanda, it's fair to say, but I think it's an important point, Michael, and one we will obviously want to come back to. So let's move on through just perhaps some quick comments now from Hugh and then John and Tim.
Thanks, Kathy. I mean, actually, a lot of it is what I was going to sort of comment on has been asked. So I'm very keen that we do create that read across to the resources and capacity. We've been talking about a left shift for a long time into community primary care, and then actually further left shift. We talk about it a lot, but actually I'm not sure we achieve very much of it. And I agree with Chris. We know the quantum to some of our deprived communities isn't right, but we've got to work out, and maybe we'll just have to take a bit of a gamble on some of that. And the other bit of that is, I think as part of that process, we need to do a little bit more work on the organisational conversations across our clinical community, that, because, if money's going to one place, it's not going to another place. And we've got to strengthen that argument across the whole of our system to make people feel comfortable and accept that, because there isn't enough money and we're all fighting for our pots of money. And we've got to do a piece of OD alongside that left shift as well. But, you'd anticipate from me, and the city really welcome this because it's a massive issue for us. But, my GP colleagues in the city would say, yes, well, let's see some action then, because actually our demand and need is massive, and it's just sort of swamping us at the moment. And we've got clinicians who know they could do so much more, but actually we need to sort of be brave and actually move some of that resources or think how we use it, and not just money, but capacity as well, of course.
Thanks, Hugh. Let's just accept that as a comment at the moment, because I think it's, absolutely. I think I can think back to about 12, 13 years ago, and we had these sorts of conversations about moving to the left, putting more money into prevention and those sorts of things, and we've just kind of not really done it, have we? But John, do you want to come in?
Thanks, Kathy. So in the interest of time, I'll make an observation rather than ask a long-winded question. So John, firstly, I think you said a lot that encourages me in that presentation. So thank you for that. there's a piece that I don't feel very sighted on, and I think it's probably the bit where we can make the biggest difference, which is what we're doing at neighbourhood level, so at that PCN level. And I think I understand that in September we're going to spend some development time discussing how we make places work best. So I'd like to understand a bit more in those sessions, please, around the levels of engagement that we have down at real on the ground neighbourhood level. I'd like to understand whether that is very health today, or is it wider? Does it bring in the other partners that it needs to if it's going to be successful? What are the levels of variation we have? Are some PCNs, neighbourhoods, working well and others not? And if so, what might we do about that? Do we have good processes for sharing best practice? And to come back to, I think, the point you started with, Kathy, how do we ensure good visibility and make sure that we hold ourselves to account for actually making progress? So I'd be keen to understand more about that particular piece in our next discussion in September, please.
Great, thank you, John. Absolutely makes sense there. Tim, I think next, and then I've got Adele and Mel, and that will have to be the end of inputs on this one. I'm terribly sorry, but we will. This is an ongoing discussion. But Tim.
Thank you. Tangential to what I was going to say, I'd support everything John said, because working at PCN level, we are starting to do that, but I'm not sure it's consistent across the piece. The point I wanted to make, this is core to what we're doing, and what we should be doing at all levels, ICS, the ICPs, whatever they are now called, and the PCNs. The question that I have is, where is the novelty of our response to this? The problems we're talking about are problems that I learned about in my sociology lectures in year one at medical school in 1990. They're the same inequalities. And so looking around the room, most of the participants, I'm sorry to say, we are all, I include myself in this, we are all architects of this inequality because we've done nothing about it since at least 1990. And I just thought the great stuff Kinsey was presenting earlier on at the meeting, where problems are being identified by direct interaction with the groups affected, and yet we don't seem to have those groups involved in the response. And if there are people out there suffering health inequality, and they know they are because Kinsey's talking to them, then surely they must have some idea how we should respond. We seem to try and force them into our solution. So let's get them to learn the NHS app. Let's make them, the app's there, let's teach them how to use it. But the app is our solution, it's not theirs. And so there's probably something wrong with it. And so where is the novelty in terms of actually getting those disadvantaged groups sat at this table, having this strategic discussion with us? Because they are not the architects of this, they're the victims, and we probably largely are the architects of it.
I think really well said, Tim. And I think, I think that was a very inspiring story, wasn't it, earlier, the discussion that Kinsey had with us. And I think there is something here. And I just wondered, John, if we can ask, and I'll probably, when I do my summing up, just add this, is how do we see the voices of the people who are affected, if you like, the people we heard about from Kinsey in all of this, not this business of, we've created something, what do you think of it? And I just wonder if you could take that into that. So how do we actually do that? And it may be, as you say, that it's at neighbourhood, it may be at place, very much more difficult, perhaps around a table like this, if you like, but it's not impossible. I don't think it's impossible, but I think it's a really good point you make there, Tim. And my lecture in 1977 was the same. So sociology in 1977, I'm so old, but it just shows it has been going on forever. Let's move on before I get stuck in the past. Adele, and then Mel.
Thanks. I think, a great point there made around, and I think around the voices of people who are impacted by health inequalities. I think that's one of the things we want to address through Health and Wellbeing Board, bringing in a really almost like a standing panel of community members who have experience of the issues that we're seeking to address. There's terrible noise on this meeting, actually. I don't know if everyone else is suffering the same thing. But anyway, really co-producing that response. So we use the intelligence we get from our citizens, the intelligence we get from our data, which is kind of the other end of the same thing. And we use that to really inform and build our response, and then also check against. So it's about the visibility of inequality, isn't it? But also the visibility of the drivers of health inequality, which are things like poverty and access and so on, and air quality and all those huge things that it can feel very difficult to have an impact on. But we do spend a lot of money on our patch. We do drive a lot of journeys on our patch, and we do have a lot of interactions with citizens, all of us in our different ways, and we are able to really make those interactions work differently with things like trauma-informed practice, with things like and then as employers and spenders of the pound across the patch, do we make everyone work, every pound work to the benefit of our citizens in all possible ways? So being good employers and that kind of thing. So I think we can create a sort of upward spiral in inequality. We don't control all of it, but we do control. We are able to make an impact. And I think what is good is and I do come to this relatively new, but it is great to see the will to address these issues, and also our willingness to build those into the system architecture. And I think that may be a new factor. One of the things I wanted to put into the partnership agreement around the reason for putting those additions into the partnership agreement is about tying the resource to what we're trying to do with our outcomes, and also to make sure our outcomes are sufficiently about the wider determinants of things that we know are in that 80% space that Chris talked about. So anyway, I'll hand over to Mel. Thanks.
Kathy, is it okay?
Yeah, Mel. Go ahead, please.
Well, Kathy, just a tribute to you. It was a bit of a cheeky hand because you had indicated the guillotine, so I will be quick. So I put some comments in the chat which sort of echoed some of the comments that have been made, so I won't repeat those. So I suppose all I would say is the anchor institution point shouldn't be lost in terms of the role that we can all have. And then I suppose the other thing, just kind of going back right to the presentation at the beginning, how can we make sure that we can accommodate things being a little untidy in terms of working differently and experimenting and piloting a bit, which I think kind of echoes some of the comments that are being made, because the reality is we've got to allow other organizations to kind of come in, and it will be untidy. And therefore I can see a reference to the kind of co-production point. So Kathy, thank you for your consideration. You had indicated the guillotine. Thank you.
As you'll have worked out, I try and indicate these things and then I give in always. So I don't know what that says about me, but no, I obviously important points. So thank you very much for this, and thank you, John, and thank you, Chris, for coming along and helping us. Just a very quick summary. It's probably not, I'm not going to encompass everything here, but I think it's been made, the point's been made a number of times. This is at the heart and core of what we do. And I think we will come back to this endlessly. And if we don't, well, frankly, I don't know what we're doing really, because number one of our priorities is really to reduce inequalities. I think the point that that's come up in various ways of linking it to how we distribute our workforce, in which bits of the whole system we do that, and how we use our resources. I'd like that point to be particularly captured, because I think that's something we're not yet mature at and we need to think about. So if we could capture that, do tell me I'm wrong at the end of this, but anyway, measurement and outcome. I'd really like to start from now so that we have a clarity about what we're measuring now, so that we can see what impact we have. And I think Adele makes the point particularly around this impact all the time. And I think that's articulating something we all feel. We need to see that impact. I'm glad, Mel, you brought up the anchor point, because I was going to mention that, because I think, you know, when you add together, as I say that all the time, don't we, add together the resources of all our organisations and the ability we have to influence employment, but procurement, all these different things, we have a huge potential amongst us. So I think that's another important point. And then I suppose finally is the business about how we do this at every level and how we get that voice from the people and link, if you like, the earlier story around citizen involvement with all of this, and keep in mind it's with you, not to you, sort of thing. You know, we actually do develop things that help, but being able to move forward and make a difference here could mark us out as a system that means business, and we're actually doing what we say. Primary care is something we will come back to. I think I've said before, I'm very keen, I'm really conscious it's a very, very important important to the backbone of delivery of care, very close to people. The one thing, you know, there's a few things we all have, but one of which is you know, the potential to have a GP registration, and that's a unifying thing, and I think we could do a great deal here in Nottingham and Nottinghamshire on this, and I know Stephen Short's giving a lot of thought to that, no doubt involving colleagues around the system. So John, really great paper, really great to see this back at the heart of things. We'll take it forward in an ongoing way, not, you know, we'll come back to it in 6 months, but this will become a theme that we discuss all the time. So thank you very much. Is that okay for you, John? Anything else you wanted? We were here to be assured that progress was made, I think.
No, thank you. Thanks, colleagues. It's a really helpful conversation, some good, really good commentary on where we've got to. And I would agree. The only other thing I'd add, Kathy, is we need to be careful we don't try and do all the things to everybody all the time. So we do need to have a bit of focus. But at the same time, I really sort of the comments from Tim and Mel chimed around. We've got to be a bit disruptive, I think, and not be afraid to fail and give things a go, and spend a bit of cash, even though we haven't got any, to see if we can get things to shift that dial. Because a lot of the traditional ways we've tried, as people have said, haven't really got us to where we'd like to get to. So thanks for the opportunity, and we'll use that expertise to help inform the next time we come. Thank you.
Great, thank you very much. With that, thank you for that, John. Let's move on then to provide a collaborative scale. Now, this is an item that we want to endorse, so we want to actually agree this here today, or indeed not agree if you don't want to agree, but this is an opportunity to really approve this. So I'm going to ask, I don't know again whether it's who's going to kick off, whether it's John, Paul or Tim, but I'll hand over to you to think. Again, we've read the paper, and there's been a lot of discussion about this, bilateral and joint discussion. So I am hoping that this is a relatively straightforward item. Who wants to kick off?
Kathy, it's Tim. I'm happy to lead off briefly, if that's helpful. So as you say, Kathy, there's been a number of discussions around this, and I think from a full board perspective, the last time that consideration was given was at a development session where this was focused on. And I think one of the things we reflected on the back of that was from some of the feedback. At that point, it was recognised there wasn't full alignment and understanding with everybody about exactly what this was. Now, at that time, we were also awaiting the national guidance, and so in line with the other transition group work streams, we set up the provider collaborative work stream and have been doing work since then to try and move down that journey. The paper is kind of got two parts to it, really. The first is just flagging that from a provider collaboratives perspective, there are multiple that the work stream has been overseeing and ensuring progression of. But this one particularly brings to focus the ICS provider collaborative at scale, and that's the key one that we're wanting to get the endorsement of today. And through the discussions I think we've had, there were probably two main areas which we felt there wasn't necessarily the understanding and alignment around, which we hope this now brings together. The first, I think, which is really important for us all to be comfortable with, is how provider collaborative work sits in relation to the other elements of work, such as place, such as bilateral relationships, such as existing relationships. And we understand that there has been nervousness of what has the development of the provider collaborative national guidance meant in relation to that. So hopefully what this reaffirms is there's a very clear place for all of these. They're all important and they must be respected. And this isn't looking to move into a space that supersedes anything that has been previously in place or working effectively. This is about the three primary statutory organisations within the ICS coming together and focusing together on the things that make sense to focus at together rather than in a different way. And I think importantly, what we've tried to draw out of here in terms of the purpose, and that's where we reverted back to, is the purpose of this three-way organisational working together is any areas where we can collectively serve the citizens that we serve in a better way as on a tripartite basis than we do individually, bilaterally, or at place level or anything else. So hopefully that positions much more clearly, I think, what the scope and the focus of it is. And then the other part that I think that there was the query about is, okay, so exactly what pieces of work will come into this? And so within that, we've outlined that the primary areas is going to focus on our work around elective, where it sits with particularly within the pathways sit particularly across the three statutory organisations, anchor organisations where the three can make a significant step in that, and that's something we've heard about a lot about already today. And I think we know we'll all be doing work on that, but it will be if there are particular things the three organisations can benefit the population by pushing forward together around. And then within the national guidance that has then latterly come out, there are examples from elsewhere in the country of what other provider collaboratives are doing. So we're reviewing that now, and we will take stock of, would it make sense for any of those to be done at a provider collaborative at scale level in our ICS? Because for some of those done within provider collaboratives in other areas of the country, it might not be right for those to be done within the provider collaborative in Nottinghamshire, and we will only adopt the ones that make sense at that level. So what the paper then seems just aims to outline is that's where we're at. As has already been described, the goal for us all now is to get to a starting position by April 22 of an effective functioning entity. And as part of that, we need to have an effective functioning provider collaborative in place by April 22. So we've outlined the proposed next steps for that. And as part of that, we're proposing to have in place a provider leadership board as being the formal bringing together of the three organisations within the provider collaborative, and that's one of the nationally recognised ways of setting it up, which in effect is the one that represents greatest collaboration as opposed to any single organisational leadership taking superiority across others. So if I pause there, Kathy, hopefully that just draws the main parts out of the paper, which I hope is clear, but I'm sure Paul or John and I are happy to take any questions.
Thanks, Tim, very clear, and I think adds to the paper. Can I just invite the colleagues, Paul, Paul, you may want to say something, for example, or John?
Yeah, thank you. A couple of things. Firstly, Sherwood Forest Board received this and endorsed it earlier today, so it's got the full support of the Sherwood Forest Board, who were really clear in a previous discussion that place-based partnership working was key as to sit alongside this. So we're clear at Sherwood Forest that this enables the three NHS statutory bodies within Nottinghamshire's ICS to collaborate where it makes sense to have that at-scale approach, and also that there's collaboration at place level where that makes sense to have that approach too. Thank you.
Brilliant, and I think you've captured that really well. The two, because the world can be a bit confusing at the moment, and I think that's identified it really clearly, Paul. So thank you for that, John.
Yeah, hi. Thanks. Not much more to add, really. A similar conversation we had at the Notts Healthcare Board next week, and I'm expecting similar approval and joy. I think this is, I mean, Tim said it really, but I think this is a really significant step for the system. because I think there's an awful lot to go at here, particularly from our clinicians' perspective, linking both across the organisations but also into primary and community care. And if we can get this right, I think it will both add massive value and be also a source of some efficiencies to enable us to do that left shift. So I think this is a really exciting venture. Thank you.
Great, thank you, John. I was going to just ask Rupert, who's already put his hand up, which is great. Thank you, Rupert. Do you want to just give your thoughts? We've heard about the two boards for Sherwood and Notts Health. Perhaps you could give a perspective.
Yeah, of course. And yeah, similarly to both Sherwood and Notts Healthcare, we're really enthusiastic about the opportunities that that can flow from this. And if we're going to make a success of being an ICS, then this is, I think, one of the important sort of underpinnings of that, and allowing us to really think as a collective about how we meet the objectives that are set out the ICS. So we fully endorse it as the others do. So
brilliant, thank you, Rupert. I think it's probably worth saying though that just because you have a provider collaborative working on certain things, it doesn't mean that the provider collaborative isn't engaged with all the other parts of the system. They're not able to do anything without engagement with primary care and so on and so forth. But that's where as well, we think about place and how that happens there. We have to be conscious, of course, that we have got Bassett Law, and so that there'll be a link out through to Bassett Law Hospital, which is part of the Doncaster and Bassett Law. So they kind of straddle into South Yorkshire, but we'll work on all of that as well. So I'm hoping that, given we want to approve this today, and I think as John said, it's a really important thing for the system, and it's a really important milestone on our so that Amanda can tick off the things that we have to have done is one at a very sort of, oh dear, processy level. But I think the more fundamental is it's a great show of that collaboration and the potential for good that can come of it. So are we content as a board now to support this direction? It will evolve. It will evolve. So
Kathy, I've had my hand up for a bit.
Oh, I'm so sorry.
I can't see it. Because I'm not content, really, I'm afraid. I don't want to rain on anybody's parade.
Okay.
But we've spent a lot of the meeting talking about how we need to influence what happens at PCN level, how we need to work together, how we vitally need to involve primary care IT systems in terms of population health management, addressing inequalities and making the system change. And we also know we're working in a system that isn't financially viable if we carry on doing what we've always done. And we know, well, we certainly know as GPs that that the kind of care we can provide and the kind of change and influence we could bring to bear on the system is misunderstood repeatedly at secondary care level. And so I just feel that to have the largest provider of healthcare within Nottinghamshire, if you look in terms of number of patient contacts excluded from this provider collaborative, is a big mistake. Simply because I think if we are trying to get over the hurdle that historically GPs have been difficult to engage with as providers because we work in a piecemeal fashion, but if we're looking at the drivers of bringing care closer to the patient, addressing inequalities, and looking at the way that we could use the skills of GPs differently to support the system, then any strategic discussions that happen without significant representation of primary care are going to produce solutions which still have this artificial boundary between primary care, secondary care involved in it, and therefore will be solutions that will just potentiate the problems we've always had, in the same way we talked about with the sociological things that have been with us since 1977. I really think GPs are senior doctors in a way that is not understood by colleagues in secondary care sometimes. And so we have a huge amount of untapped potential in terms of working at senior doctor level at a round table at an equal position with our health colleagues in the acute sectors. And if that potential is unleashed, then real and genuine change that could lead to better care in a system which is financially liquid is really possible. But I'm really anxious that if the three statutory bodies get together and strategy is driven by that massive structure without taking primary care into account, then actually not much change can come of that while primary care is allowed to carry on, if primary care is allowed to be a equal partner.
Tim, I'm going to have to move us on fairly
No,
quickly.
that's
But
fine.
Amanda, I think there's some requirements upon us as to what we do. And I think, Tim, I absolutely agree with you in terms of, the primary care, which is why I did raise the point that, just because we have this provider collaborative, obviously it would go nowhere without that close engagement with primary care. But Amanda, do you want to just sort of come in there and share with us what the policy situation is, etc.?
Yeah, so thank you. So I think, it's a bit of an artifact in some ways. So I completely agree, Tim, with your sort of analysis of the situation. I think in terms of the provider collectives at scale, they are for a specific, there is, as Kathy says, there are some requirements that we are going to need, and provider collectives at scale are one of them. But that doesn't mean that general practice isn't an equal partner in the system, the whole system, that it's just one component of the overall system. And one of the key roles of the Integrated Care Board will be to ensure that that we are putting the, if you like, the pieces of the jigsaw together in a way that does start to move the dials, and that there are, there's a sort of this very collegiate ways of working across the different clinical professions and groups. So I think you're right in the expression of the critical role that primary care has to play. I think we need to find it's a different mechanism in terms of how the architecture is being developed, and over time, who knows what will happen with those provider collaborators. But I think it's the policy direction is very much, and it will be, I think, it will develop in terms of how outward facing it is, but there is a lot in terms of core kind of mutual aid, waiting list management, or some stuff that will be sort of urgent things, to address initially. So I think between us, Tim, we need to find a way of doing what you said, but I think the mechanisms of it will be different. Thank you.
Yeah. As I say, we want to bring primary care absolutely to the fore, and we'll no doubt, Amanda, I think, have a whole session at the board on primary care. So, and those links are critical. They're absolutely critical, Tim. So your points are well made. But with that in mind, and keeping that in mind, are we content to support this as our provider collaborative at scale? I think we are, aren't we? There have been so many discussions now. So brilliant. And thank you very much to everybody who's worked hard. It has been a little tortuous, and we have sort of stepped forward, back a bit, and then forward. And I think that's been good, though, because it's now got to a place where I think we've got a good shared understanding. Excellent. We'll move on, I think, if that's okay. Amanda, I think it is you next on... and I've just slipped a bit on time, if I can look to you to help me a little on the improving population outcomes through our signature schemes. Thank you.
Thank you. So, yeah, I just wanted to highlight some points from the paper, really. So this is an update on how we are developing our approaches to work more collaboratively, and also to embed an outcomes approach. We've called them the signature schemes because they do signify a different way of working across the system, and they are a bit of a test bed for that. And the three areas that we've selected are the community care transformation, children, young people, and integration of person-centred commissioning, which is sort of packages of care, continuing healthcare, personal health budgets, those types of things. So each area has identified some outcomes, and there has been significant engagement over the last few months, actually, to get a very aligned understanding and commitments across all partners. And as has been highlighted a couple of times, we have got the analytical support now that can underpin these pieces of work. So we are now, having done a huge amount of engagement across partners, our next stage is to develop the sort of implementable plans, so that as we go into 22 financial year, we have got plans that we can actually put, embed and move resources around, etc., in order to be able to do these. So for community, there are co-production workshops. There's been an evidence trawl around what's best practice, not just kind of based on historical patterns. And the co-production workshops are taking place imminently to develop the blueprint for the services for children, young people. There's an integrated care model. We are sort of bidding to sort of be a bit of a forerunner on some of this. And some frameworks around placement, how we look at placement needs differently. And I think it is that and the integrated personalised commissioning ones are really important areas, because we know that at the moment there are cracks between services that people fall between because of the, each service has its criteria and people don't necessarily slot into those criteria, as the point has been made previously. So we need to be wrapping services around more individual needs, not expecting people to fit, necessarily our sort of diagnostic criteria in the way that we do. We've strengthened the clinical oversight arrangements around this, linked it to our long-term plan priorities, and also it's proposed that we refresh the healthy life expectancy baseline on that as well, the data and how we're going to approach that. So I'm really brought this just to ask that the board notes the approach, notes that we've moved forward now with making sure we've got the analytical support, which is focused on outcomes as opposed to some of the kind of traditional transactional activities. Asking that the board endorses the refresh of the healthy life expectancy ambition post sort of taking COVID into account. Very happy to keep the board updated as the implementation plans emerge in the three areas, but I think the groundwork that we're doing now to embed these approaches is it's got a lot of engagement, a lot of momentum and energy behind it, and I think it is something that we are progressing in a way that will set us up better for the future, I think. Thank you.
Thanks, Amanda. So that's good to hear this progress of this at the same time as we're doing all these other things. I'm sure there'll be some thoughts about how do we see the impact of all of this. John Towler, did you want to ask anything on that?
I think all I would say is the paper is helpful insofar as it's clear that we're trying to do things. So we have a way forward. I think as a board, we would be wise to get into a really good way of working that gives us absolute clarity on who's doing what, and then have a clear methodology for being able to test we said we would do, and we did, and we have good enough data presented to have evidence as to whether it's making a difference. And I think this paper is perhaps an example of how we're not quite there yet. But I do note that in November, you're proposing to give us the outcomes of the healthy life expectancy discussion that you're working through. And I think we should use that as an opportunity to make sure that we have confidence about do we have useful outcome metrics, and do we have the resource and the processes in place to capture those effectively. I guess those are my thoughts, Kathy.
Yeah, I think it is always about how do we show that what we're doing is actively moving forward and is making a difference. It's a kind of theme, isn't it, really, all the time about how do we do that. But with those things in mind, and assuming nobody else has got any burning questions, are we content to note the progress on this and the systems analytic unit, and also endorse a refresh of the ambition around healthy life expectancy, something that was brought up earlier, I think by Michael, but are we content with that? It'll come back, it'll keep coming back to the board. Important that we have these three areas that we keep moving on. I'm not seeing dissent, so I'm going to accept that on this occasion, though I have been burnt by that before, but I will accept that on this occasion. Amanda, thank you very much for that, and thank you for continuing to oversee. As we go forward, it will be helpful, I think, to hear from the people actually doing the work from each of those streams, and actually sort of get into a bit more of the reality of that, but that's really helpful. Okay, so I think it's you again, Amanda. We've got the integrated performance report, which again is something that people will have had a look at and will want to focus perhaps on some questions, but I think you'll want to draw out one or two key points, won't you?
Yes, thank you. I mean, just to conclude that, I think just to say I completely agree with the direction of travel. I think it's an example Mel mentioned around we're going to have to go through some messiness. There is a bit of messiness in those signature schemes because it's quite challenging, because it's with different ways of working. So just an observation there. So in the integrated performance report, John mentioned earlier, he drew our attention to the significant pressures across the services, and I did want to sort of reiterate that as part of our of this report. As COVID restrictions have eased, we have seen, really very significant pressures on all of the services, and we are in a third wave. So at the levels of our hospitalised patients are more than half of the first wave, when we had sort of decanted hospitals, not quite knowing how the virus would behave. So despite our very successful vaccination programme, we still do have significant numbers of people in hospital with COVID, and people actually in intensive care unit with COVID as well. There are also, as it describes in the report, some pressures on our learning disability and autism programme, particularly around the ability to discharge people and move people onto the next stage of their lives. So again, it's having a sort of knock-on impact on a number of areas. More positively, actually, the fact that we were an elective accelerator programme has helped to accelerate our return to planned care levels, and it has brought a significant benefit for our population, and we continue to embed some of the learning from that. But we do still have significant waiting lists for treatment, and we are having to make some choices around time critical and cancer patients as well. In terms of our financial position at the end of the first half of the year for the NHS part of the system, we do have a 7.5 million adverse variance to plan, which we have notified to NHS England, and that has been specifically in relation to some rule changes nationally around the income that we received for elective activity. So that is a known and understood, and it's because of the rule change midway, really, or at the end of Q1. People and culture, we've mentioned that, and that is really a critical or the most critical part of the services and the things that we're able to offer. There's been a focus on staff recovery in the first quarter of the year. We are still running at quite significant sickness levels, around 2% COVID related absences as well, and that's been pretty constant, and that adds to the pressure on services, and that has meant that there's more reliance on agency staff, and there are other absences related to, you know, sort of stress and burnout as well, as a result of COVID, so indirect. Our substantive numbers have remained static in the NHS part of the system, and there is an increased focus, as you'll see, on international recruitment in some particular hotspot areas for registered practitioners. And there's big focus on retaining GP trainees as well. That's really critical. In terms of the report, it does also highlight some inequalities data, and particularly the higher use of accident and emergency presentations in the more deprived populations, and but lower planned care access, which suggests later presentations, and as at least in part to explain that. And we can see those patterns in our place-based partnerships as well. There's some different service utilisation, some of which I think we probably do know the reasons for, but not entirely. So again, I think that's for further work with our place partnerships. Thank you. Those were the points I wanted to highlight, Kathy. Thank you.
Thank you. There's quite a lot in the report, and obviously people will have read that. So this is a chance. You can see in the report as well, there are named individuals who around the table who could answer on specific things. So if there is anything, Hugh, do you want to come in there?
Thanks, Amanda, for that. It was just something we were discussing at the Planned Care Board yesterday. You mentioned the sort of general pressures, but obviously with COVID, what's happened, there are substantial waiting lists. And I think there is something about having that transparent, honest conversations with our citizens about the realities of where we are. And do we, obviously, a lot of that's been led by national NHS comms, but I think there's something for us as a system to start to think how we have those conversations with our citizens, you know, because we want to be open and transparent. The waiting lists are very substantial. There's a lot of challenges in the system, and some people are going to be waiting in discomfort and pain, and you know that's not what we want, but it is a reality. And I think we've got to try and set the expectations. I think there'll be potentially a political expectation that the NHS is going to recover quickly. But from my perspective, I think it's much more complicated than that, and it will be citizens suffering. And I think we need to have those conversations and get on the front foot of that if we can. And I'd just be interested for us at some point to think about how we start those conversations and get on that front foot, Amanda. Thank you.
Thanks, Hugh. I think this is a point that, you know, those of us who also live in hospitals and so on are very focused on. And I think it would be quite helpful, Amanda, if as a system, we could think, just building on what Hugh has said, think about bringing back something on how we're communicating with the people who are waiting, how we communicate with our primary care colleagues, because at the end of the day, you probably have to take the brunt of the queries and so on and so forth, but also how we are looking at any harm that may be accruing to people who are on waiting lists, or you know, any consequences when they have been operated on or treated, or whatever the approach is. But I think those things, you could argue that's all being done within individual organisations, but I think that as a whole system, it's the sort of thing that would be really helpful to have an approach to, and I think we should bring that back, if you agree. I don't know, Hugh, if that would be a helpful thing to do, and obviously not just bring it back, but do something about it between now and then.
Okay, but I think there's a sort of planned care part of the system that's trying to do that, and I think we can pull that together and bring something back. But as I say, I think it needs to link in with some of the so what questions of that sort of conversations. You know, we talked about engagement, we talked about co-production throughout this, but some of it's having honest conversations as well. But I think it'll be useful to have a bit of time to think about that, and that broader conversation of that, because I say you're quite right. My colleagues in primary care generally bear a significant brunt of people who are in pain and struggling and not going to get their operation for quite a long time.
Yeah, okay, thank you, Hugh. Any other questions on any aspect of this. Adele, you did mention that quality was coming up later, and here it is. I know you had to step out briefly. I don't know if there was anything else. I think we've got Rosa with us.
I think, or just to come back to that point around the difficulties that some of our citizens are going to experience, and I would advocate being really honest with people. You know, obviously, I'm a politician, and you know, some of this is stored up and isn't entirely. Obviously, COVID has created a crisis that has meant that this has happened recently. But this is you know, we've talked earlier about long-term funding issues, and without straying into areas of politics, it's not entirely down to COVID. And as you know, the other part of that, of course, is as a system we need to come together to look at the workforce issues as well, that you know that we've talked about already. But I would absolutely agree that we need to be straight with people so people can understand the pressure in the system. I think people are really actually quite well sighted on that through, you know, both through their own experiences and what's in the media. But I agree. I think the more transparency we can offer around that, the better, and that will really help with that, you know, trusting relationship we have with our citizens. Thank you.
Good. Well, thank you very much, Amanda and colleagues who've put that report together. You know, obviously is in development as we move forward, and you see the dashboards and so on, which again, you know, I think will evolve over time as a system sort of approach. Right, Stuart, we've touched on finance slightly, but do you want to?
I do. Thank you. Yeah, just I suppose a couple of things to me really, just to report back that the finance directors to continue to work together positively in terms of managing both the in-year position in this year, in the first half of the year, and also taking an eye to the future by working together to co-produce a finance strategy across the system, which is going really well. This work has been shared with the regulators, and I think they've been pleased with the work that we're doing, particularly around the finance framework. And it's that I really just wanted to touch on today in conversations with the regulators. Although the finance framework has been co-produced by the finance director network across the system and has been shared and endorsed by the chief execs, the request was, could it be adopted and approved by the ICS board? So I have cheekily taken this opportunity to append this to an update report to seek the approval of today's meeting for a document really that just, I think, lays out the transition really from organisational thinking and working to that of a system, and starts to highlight the behaviours that we need to adopt and the way in which we need to work together, and how we will start to think about some of those prioritisation and dispute issues sometimes where we disagree as well. So hopefully it was a relatively light read for people, and I'm hoping that people would feel able to approve that today. Thank you.
Thanks very much, Stuart. I think we've got a question from Tilan, but I think, you know, on the one hand, you could say, well, this is largely NHS, but actually it's not completely, is it? You have got an element in that framework around working between local authorities and the NHS, and also with city care. But Tilan, do you want to come in?
Thanks, Kathy. Stuart, thank you very much for this. Yes, it's a very helpful read, and I agree with it. But my slight query is a bit similar to the conversations which we've just had about the primary care involvement. And I know under 12, with regards to local authorities, city care, and third-party providers, and I'd probably put ICPs in that other same bracket. Developing PCN providers have this, then standard contractual mechanisms exist for the financial framework. I think my pushback with is the current contractual mechanisms in primary care aren't truly reflective of activity or the cost of the systems. It's more historically based on GMS and PMS contracts, And therefore, even when we start discussing about the provider collaboratives and thinking about left shift, it might very well reduce the cost in a part of the system, but it might not necessarily be a net reduction when you take the system as a whole, because we just discussed about the constraints across NHS and primary care. So my question is about how do we tackle the issue about, again, looking at the funding element across the system, not just necessarily what can be counted based on the activity across the main trust providers. So, for example, if a referral has been generated by a GP, you've missed the opportunity, and this includes taking into account prevention and shared decision making, etc. So how do we get the PCNs, the GPs, to be involved in this shared decision making about finances as a system? So that is what I need to clarify.
Sorry.
No, Stuart, I was just going to say something that I think this for me is a real opportunity for the system, isn't it? But it's not necessarily something we will have solved as such by the 1st of April. I'm looking to you and Amanda, Stuart. But I see this as part of something that is the permissive bit that we need to take a hold of ourselves, don't we, to make it work, Tilon, otherwise we never will. But Stuart, sorry, you come in.
Yeah, I've picked up a real theme today about how we can pick up some of those things and take them into the planning process. I think we've set the structures up, we've set the link between the ideas and the clinical executive group, and we've got a lot of representatives there from primary care, and I think it's how we make that real. So I think in terms of this particular framework, it is in a sense managing the control totals of the CCG and the NHS statutory organisations. But I think we can have a really good debate outside of here and make some suggestions about how we can do stuff that's more transformative in terms of the left shift, as it's called, and also looking at how we sort of incentivise and manage that demand through primary care that you touch on, as that's where the resource decision is being made. It's not the order, it's the requisition of the care that's important. So I think we'll take that on board and take that helpful contribution away, Tilan. Thank you.
Thank you. And Stuart, I think one of the key principles would be surely the rules around the money shouldn't get in the way of us doing the right thing for the patients or the public. I think that's the key thing there. 2 more we'll take on this. I'm conscious I've sort of slithered on time, haven't I? 2 Pauls then, Paul Devlin and then Paul Robinson.
Thanks. Just comments from me, not questions. I was pleased to see the section in there about local authorities, city care and third sector. I think, I don't know if this is just me or is more about us as a collective, as a board, but I think we need to better understand our collective finances and financial challenges and that wider resource that we've got, because the conversations that we've had earlier today have been about us doing things differently and potentially focusing resource differently. And I'm not sure that we're as well sighted on this as we need to be yet as a board. And I think a part of that, and I appreciate Stuart, that this wasn't intended with this paper, so it's not a criticism of this paper, but I think as a board we need to be better sighted on some more granular data around the numbers and those financial challenges and the way the patterns of change of that, and to be doing that in our public domain as well, so that the public are seeing what the scale of some of our challenges are, but are also seeing where we are potentially having some of those impacts. But as I say, Kathy, not questions particularly. Thanks.
No, well, thank you, Paul. I think that's helpful. Stuart, I just, looking to you and Amanda, I think that we should probably map in a board discussion that's not just towards the end of finance, but one of our sort of early on the paper or early on the agenda discussions that actually sort of brings together some of these things in a triangulated way. How do we use the money and where is it going at the moment? How do we make it do what we want it to do across the system?
I'd be pleased to do that.
Yeah, that'd be great. And then let's have some discussions offline as to when we could fit that in. And I think, as Paul says, we should be doing that transparently as well. After all, we are funded by the public reserve. So this is important. Paul Robinson, last point on this, and then I'd like everybody to think, are we content to support Stuart's paper and framework in particular?
Yeah, thank you. I'm very content to support Stuart's paper and had had an early insight into it as part of the genesis of this paper, as part of the finance directors group. And just a couple of points. We set out as a finance directors group to describe how we might work together in terms of initially the challenges set by NHS-EI to the NHS providers and the CCG's financial position during the planning process. So that's where it started. We tried to encompass other strands, other partners, and other developments. And I just see it as a sort of a position statement. It's the launch pad for how we work together, how we develop a financial strategy, and how we work together in the future. For what it represents today and how we're going to work together for the rest of this financial year, I think it presents a really good start point. I'm happy to endorse it.
Okay, thank you. Is anybody object to us endorsing this paper and then bringing back something as a wider discussion here in due course?
Okay, thank you.
Thank you, Stuart. And everybody who's contributed. So, conscious of time, the next item is actually for information more than anything. It's a report from the quality group. Rosa, are you there?
Happy, yeah.
I'm going to assume everybody's read it. Is there anything in particular you absolutely wanted to say, or can we just ask if there's any particular questions?
Happy just to take questions on it, Cathy. I think most of it's been covered in either Amanda's report or the development of the new structures around the ICS.
Yes, I thought it had been largely covered, and it was presented for information. So I'm going to propose, unless there's anybody shouts out quickly. Adele, yes, you've just got in. Well done.
Sorry, apologies for that. Sorry, and if this came in when I was just had to pop out for a minute or two earlier, I just wanted to flag just really just to ask what, as a system, what else we could be doing, what partners around the table could be doing to assist with the issues that are flagged around quality and patient experience at our key providers. I'm thinking particularly around NUH. What can we do to underpin the process of improvement and challenge and support?
So I'm quite happy to sort of go through what we do have, because we've developed some quite strong structures for doing that. So the Quality Assurance and Improvement Group, which has been set up, has representatives from all partners in the system, including our local authorities, some of our independent providers, and really gives that ability to both share good practice, but also hold up a mirror in what is a fairly frank and open system space. So that's the first thing we do. For all of those areas where we've reflected there's enhanced surveillance, and we've used that term carefully because we're system partners, we're not regulators of each other. So that terminology is very carefully used. And what we're doing is working together to have a really clear system action plan, which isn't just owned by a single organisation, but reflects exactly what you said, Adele. Where do we have other parts in our system that can help and support? And we've seen that work through in action in a number of the areas. There are also, for each of those key areas, a system single item quality assurance group that have people from across our system, including Director of Public Health, CQC, NHS, E&I, and representatives of many, if not all, of the organisations on this call that do exactly that. They do some really constructive challenge around our expectations for our citizens and what all of us, including the providers named, want to see, but also then a really supportive offer about, so as a system, as partners, how do we make the change that we need to see? So I'm quite happy to share after this meeting an example of how that's been done in NUH maternity. We've shared that as part of briefings with a number of people. But there are some really clear structures in place that allow us to have a very system approach to working together, both around the assurance and the improvement elements of quality.
Thank you. And I think, Adele, just for further assurance, I mean, I think Eric and Rupert would know there's endless discussions with you, isn't there? We had one only this week, in fact, and you know, I think in some ways you reflected that you've got many offers of help, and actually one of your jobs is almost to sort of filter out, you know, where those things are going to help. But I think we're in close touch, aren't we, between us all, so that if there's anything needed, you will shout. But I think Adele's right. This is, as we've talked many times, and Rosa knows, it is a system to support, and we are partners in a system, and therefore, you know, any one bit of the system's got an issue, we've all got an issue. So it's a joint and several thing. Eric, did you want to come in?
Yeah, just endorse what you said, Kathy. We're getting lots of offers of help, very helpfully from across the community, and also from NHSCI, who are working really well with us, and they've been really good with their offers in the last few weeks. Some of it is about sifting the help, because you need to get the timing of the help right, so we don't get too many players on the field getting in each other's way. But I have to say, I think we're able now to develop work with our partners to help us turn around NUH, because we're facing some serious issues. No question about that. We're not going to deny that, and we need to put things right.
Thank you, Eric. Tough times, but you know, we're here alongside. Adele, is that okay? Is that help assure that, you know, everybody is on these matters?
Thank you.
Can I move us on then, because I have kind of run out of time really. But John, you've got a report on the transition. Again, we've touched on quite a lot of this, so if there's anything that you particularly feel we ought to have highlighted that we haven't touched on, but otherwise I'm sure everybody will have read this, but over to you.
I can be less than 60 seconds probably. So the headline is we are on track with where we need to be at this point, which is good. I think you've said earlier, September feels as if it's a key month, and I think for transition and getting to where we need to be for the start of the next financial year, it is a key month. So I note that we have a couple of very important development sessions scheduled during the month, which will pick up some of the big outstanding issues, particularly around the ICP, so the Integrated Care Partnership, the ICB. And I think we need to make sure that place is on that agenda. It wasn't in the table that I think Rebecca put up earlier. So I think we just need to make sure place is in those sessions, particularly how we give places what they need to make positive change happen. And obviously by the end of September, we need to reach consensus on those big outstanding issues. Having said that, I think October will turn out to be a key month as well. And our development sessions for the ICS board will pick up some key issues around data analytics and the IT work stream, and particularly importantly about the people and culture function and how we make that fit for purpose as we go into the next financial year. So those are the headlines of where we're at, I think, Kathy.
Thank you very much. Has anybody got any queries on the report, which is reasonably self-explanatory? But John Bruin.
Yeah, thanks very briefly, Kathy, and thanks, John. Just to echo and welcome the focus on the people and culture function. Amanda and others will know that it's something that I've been going on about for a while. I think it's a critical factor for our success, engaging our staff and all of our broader workforce and volunteers to be part of this conversation transformation. I think I really welcome that writ large in the paper. Thanks.
Yeah, good point, John. I think that is really important. So I think we're coming to the close. I think in my rush to move forward, I forgot to say thank you to Rosa for her paper. So thank you, Rosa, for your paper. I just scuttled on by, didn't I, really? And thank you, John, John Towler, for overseeing the transition and risk. You and I spoke earlier today, and I have great confidence that you're doing a good job of assuring us on progress. you know, lots of work going on. I could frankly thank absolutely everybody, because it is a very pressured time. But and when I look around, and I'm involved in several other ICSs, and I was saying this earlier, you know, where are we against others going forward? I think we're in pretty good shape, actually. I think some people are ahead on one particular thing or another, but I think we're quite rounded in the way we are. I think we're moving forward, you know, not with a wave in spikes, but a sort of fairly rounded wave. And I think that's a tribute to everyone. I'm sure we'll get tripped up by something along the path, but it feels to me as though we are on course to meet our requirements for April, but it wouldn't take a huge amount to knock us off. So I think it's going to have to be, you know, focused endeavour. I think that today's discussions have been, you know, feels like a step forward for me. We've agreed the provider collaborative position at scale. That's really important. And John's highlighted some areas we need to move on. But, you know, overall, yeah, great work. Thank you. Now, questions from the public. We have been trying to get some questions from the public, Joanna, haven't we? And I think as yet we haven't got any. We will keep working on this. We do need some public engagement with us, I think, and we'll have to perhaps, Alex, think a bit more about how we improve that. But you know, that opportunity remains. Review of the meeting against the partnership agreement. You will get a feedback questionnaire, because I think it would be helpful to have that, and I'd really, really appreciate it if you could put something into that. That would be really, really helpful. Just before I sort of summarise the meeting, Kinsey, I see you'd like to come in. Do you want to?
Thank you very much, Kathy. I didn't wait I don't know if there was an opportunity for any other business, but I thought it just in case there isn't, and I'll put my hand up. Just a couple of quick observations, and they're not even related. One is sort of in the context of the greater change and the transition. We discussed it about the ICS legally kind of changing from next April. Within sort of underneath that, sort of from Health Watch perspective, we're a little bit anxious about the citizens of Bassetlaw, and whether the fact that Bassetlaw CCG come now under the Nottingham and Nottinghamshire Great ICS, I mean, and from Doncaster and Bassetlaw to Nottinghamshire. And so we're a little bit in the dark how, because the strategies were drawn before that change happened, and we're just a little bit conscious that hopefully we would like to see a greater discussion that citizens of Bassetlaw are not unduly disadvantaged by the change. That's one. And the other one is I appreciate that the board has a kind of a routine practice to have a citizen story at the beginning, which I think is fantastic. But I think a couple I viewed on the public recording, and there may be a tendency of getting citizens who have a positive story to share. And I think, as Tim was saying earlier, Tim Haywood, I think it'd be great to also talk to citizens who are actually struggling to access services, so that we can highlight the gaps. Thank you.
Thanks. I mean, the Bassetlaw, I think I mentioned we've got a plan for involvement. We absolutely don't want Bassetlaw citizens to be disadvantaged whatsoever. In fact, we're delighted that we have a job opportunity to support them. So Amanda, we're doing that. And then the other point about, I mean, I think we are continuously developing our citizen story and citizen involvement, and I think we'll come back on all of that. So thank you very much for those comments. I haven't had any AOB given to me. So the final thing I would say is, just to reiterate, I think this was an important meeting for us. I hope you feel that we've covered both the things we've got to do to get ready statutorily, but also keeping a focus on our purpose and inequalities and, improving our services and so on. I think we need to think all the time about how we move the agenda around so that we have different things at the top, because there's no doubt we give more time to things at the top. It's always the case. And we will need to think as we go forward into April, once we have an ICB, an integrated care board, how we retain this kind of engagement. So that's something that I want to come back to. And you're now tantalized by that little comment, but I will come back to that, because I think this engagement and everybody working together is absolutely tremendous, and I'm absolutely determined we won't let that drift in any way. So I'm going to close this part of the meeting, the public meeting, or the meeting in public, I think it's called, and